Good afternoon. Thank you so much for inviting me to speak to you all today about the Childhood Cancer Diagnosis Study. My name is Shaarna and I am a paediatric registrar who works in the emergency department, and I'm currently working as the NIHR Doctoral Research Fellow at the University of Nottingham. So why did we embark on this? The World Health Organization declared childhood cancer as a global disease burden and have launched the Global Initiative for Childhood Cancer in order to improve survival rates to 60% globally by 2030, which, if achieved, will save an extra 1 million children's lives. In the UK, the individual risk of cancer from birth to age 25 years is 1 in 180, with nearly 4,000 new cases diagnosed each year. Importantly, the incidence of childhood cancer has increased by 15% since the 1990s. Whilst genetic predispositions are well documented, no modifiable or preventable risk factors have been identified, and early diagnosis is key for the best outcomes for our children and young people. In the UK, the overall 5-year survival rate is 84% across all childhood cancers, and this is a statistically significant increase from 77% in 2001. We know that this is still lower than in some European countries, such as Iceland, for example, where it's 91%. And part of this is likely down to delays in diagnosis. We hear every day from parents and carers about delays in diagnosis, but there is a real dearth of data to quantify this nationally, aside from in brain tumours. And so the idea for the Childhood Cancer Diagnosis Study was born, and it's been a long, long road since that conversation initially back in 2015 between Angela and I, but we are finally here. The Childhood Cancer Diagnosis Study, a collaboration between the University of Nottingham and the CCLG, funded by the NIHR to try and understand exactly what is happening in the UK with regards to diagnosis of childhood cancer. Those of you who are here in person in 2019 will have heard me presenting our plans for the study, and we are finally open after a small delay due to the pandemic. The study opened to recruitment on the last day of Childhood Cancer Awareness Month last year in 2020. The aim of the study is to understand the route to diagnosis as well as the time to diagnosis for children and young people across the UK. And this is so that we can identify any factors associated with diagnostic delays. All incident cases of childhood cancer in children and young people under the age of 18, with the ability for the parent or young person to give consent or for a consultee to advise on their behalf, will be included in the study. If they're over 18 or they were diagnosed outside of the UK, they'll currently be excluded. We're also awaiting for ethical approval in Scotland for those who lack capacity to consent to be included. At each principal treatment centre, a number of steps will be followed. Firstly, the care team will be responsible for identifying all new eligible patients. Data will be collected on a standard pro forma during their initial consultation after diagnosis. They will then be approached by the research team and given parent and participant information about the study before they are consented. And then once they consent, their data will be pulled from their medical notes and inputted into the online database for the central research team to analyse. The data we're collecting will take place in two parts. So the current 2-year data collection concerns the diagnostic data. Data will be collected, including demographics, tumour type, tumour stage, clinical risk group, referral routes, key diagnostic dates, and symptoms. Data will also be collected at 5 years post-diagnosis, and this will capture data on refractory disease, relapse, and 1 and 5 year survival. The study is taking place across 20 principal treatment centres, and 18 sites are currently open to recruitment, and the others are not far behind. The initial plan had been for all centres to open simultaneously for a 2-year period. However, due to COVID, we've had to amend this, and all the centres are now able to be open for 2 years from when they first opened. As of this week, we have 465 patients recruited, and this is all down to the hard work of each and every research team and PI at the centre, as well as the clinical care team. So we're incredibly grateful. The full data analysis will take place once all the data has been collected, and it will analyse the differences in diagnostic intervals and routes of referral between cancer types, between age at presentation, and geographical location. It will also explore any associations between intervals and patient and disease characteristics, such as staging. For the purposes of today, I'll just present the basic demographics of the data we have so far. So of these 465 patients, 51% are male, and this would fit with the latest Public Health England report, highlighting a slightly higher incidence in boys than in girls. In terms of age distribution, as you can see, this also fits with what we know. So the highest incidence being in the under 5 age group. Ethnicity-wise, 80% of the participants are white, with the next common group being Asian or British Asian. And currently, the tumour distribution has the most common type being leukemia, which is what we expect. And then our second most common type currently is lymphoma, followed by CNS tumours. Now, these two tend to interchange as the data comes in, and we still have a few sites who've had some difficulties logistically due to their CNS tumours being at a different site, which may have contributed to this a little. So overall, we feel that we are one step closer to understanding the current picture of childhood cancer diagnosis across the UK. Identifying referral routes and diagnostic intervals that our children and young people experience, as well as the factors associated with it, will hopefully allow us to make change and advocate for our patients to promote earliest possible diagnosis. We'd like to say a really, really big thank you from the CCD study team to every single centre for their hard work in setting up the study and recruiting in such difficult circumstances during the pandemic. And if it wasn't for all of your work, we wouldn't have all this data coming in. So thank you very much.